Hey everyone, and welcome to Ask the Experts. It is a beautiful Wednesday. It's morning here. Hawaii's just waking up. People on the East Coast are having lunch. People in Europe are dinner. It's a good day, John. It is a good day. That's how I feel about today. I'm going to already start. Emilio, sorry, I'm already getting you to work. I love Amy's comment at 12:02. She says, it's a great treat when any of the Johns are a guest on the live stream. Grayson, Hershfield, and Abramowitz.
That's nice.
I know you guys had that one talk that was hilarious, the Johns, and I was like, okay,
Yes.
the only Chris I know
Jon
is
Hoffman as well. Yes.
Yeah. I was like, the only Chris I know is Pittenger, and I was like, I'm gonna try to do it. We should do a rival Chris's, but there's only two of us, and you guys have four. We're gonna lose. This is terrible. So, well, welcome everyone. Thank you so much for joining. If this is a first live stream, every Wednesday here at noon Eastern, we have Ask the Experts, where we bring on experts and we ask them different questions. So the title really kind of just explains itself. But what I love about these live streams is it's an opportunity for people to find community. I know that for me, when I was part of this community many years ago, when I was really suffering, there wasn't consistent support. And that's what I love about these live streams is we can bring on different people that have written books that you've read, done webinars that you've watched, spoke at conferences, and be able to ask them questions and kind of check in with them. So I always love when people agree to come on, because I know how many people really cherish these live streams. So also don't forget, these live streams are yours. So whatever platform you're on, because I know we're on Facebook, we're on YouTube, we're on X, we're on Twitch, and we're on LinkedIn. And then you can also be watching us on iocdf.org/live. I was looking it up, John. Just since the conference, these live streams have gotten over 40,000 views on all platforms. Yeah, I was doing the math last night because I was like, so many more people since the conference have been messaging me questions and stuff when I post, and we've been doing good.
Magnificent conference, actually. It really was. Yeah, I met a lot. I see Jan is here from Spain in the comments, and I met him.
Love that.
Conference. So that's awesome.
I know. See, secretly, I want to find out where everyone's from, because then when I travel to Spain, specifically Zaragoza, then I can hit up Jan and be like, hey, how you doing, man? Let's hang out.
Yeah, it's nice to see everybody come together.
Yeah, no, it's always great to see people from all over the globe. It's a good reminder that everybody around the globe is really struggling with OCD, and that's why the IOCDF is here to support you. So although these live streams give education and community and direction and resources, the only thing we can't be is a crisis hotline or step in for therapy. But one thing that I found many years ago is my OCD specialist on the same website that's up on your screen. So head over to iocdf.org/find-help. There you can find a licensed clinician or in your area, or a treatment center, or the right kind of care that you need, a psychiatrist. Additionally, if you are in a crisis situation right now, please make sure to dial 988, go to 988lifeline.org, 911, your local emergency room, or your clinician. We can't step in for a crisis situation. And remember, we are live streaming on many different platforms. Like I said, please be sure to support each other. Jon is my guest today. I'm so happy to have Jon Hershfield. Jon Hershfield always has a special place in my heart, because there's a few people, Jon, that my mom likes more than me, and you're one of them. So she like loves you. It was funny because we got so many submissions for the OCD SoCal conference, and so we didn't see them all coming in, and she was like, Chris, you got to make sure people like Jon Hershfield and Patrick submit. And I reached out to you. I was like, please submit. And you're like, I already did. But anyway,
yeah, I was like, we met. I submitted like 8 things already.
Yes, which we're so happy to have you in November, obviously. But yeah, I think it's you, Ethan, and maybe Patrick. My mom really likes Liz. Actually, there's a lot of Allegra. There's a lot of Kim. There's a lot of people my mom likes more than me. So that's okay. I'm like 8th in line. But Jon Hershfield, if you're not familiar with him, he has a lot of things that he does to support the community. I would say one of the things that has really helped the people in the family and loved ones support group that I run, which he came in December. Thank you so much. Jon has a lot of books. And I think that as a companion, a lot of times people that don't have access to care, or maybe they do, but not at the consistency they need, a good book, a good workbook can really be supportive. So please check out Jon Hershfield. He has many different books. What to do or how to love, I never can remember titles. It's for family members, how to support somebody with OCD. But you have a teen OCD book, you have a mindfulness OCD book. Which one are you? I know it's kind of like your children, but which one are the one that you get most feedback from, or people seem to like the most?
It's different for different people. I mean, the mindfulness workbook for OCD is definitely the OG OCD workbook that gets like the most attention. I get the most feedback on that because it's really like a primer for like, so you have OCD, here's what that's like, and those who find that resonates with them will sometimes reach out and tell me like, your book was really helpful, or I'm using your book with my therapist, and that sort of thing. But then the more but when a family member has OCD, has generated a lot of like very heartfelt feedback from family members who wanted to better understand their loved one with OCD. And then the more sort of obscure niche ones like Overcoming Harm OCD or OCD Workbook for Teens, I get less feedback on that, but the feedback I get is very strong. Like, this is what I was looking for. This is the language that I needed to realize I could ask for help, or that I have something that I see in other people, that I'm not alone. So
yeah,
it's nice. The process of having written a book is definitely much better than the process of writing a book. I'm in the middle of right now going, why did I choose to do this? Who made me choose to do this? But then after the fact, getting that feedback and hearing that, I don't know, something I wrote made a difference to somebody somewhere in the world. I haven't met them, but they feel like we've connected somehow, and it's just like very rewarding.
It's funny because as the only person that's never written a book, Scott Granite is writing a book, Lauren Rosen, Allegra Castens, and like every time I talk to them, all I know is that they're stressed and tired and have no free time. So I'm like, I will not take, well, I have been approached, but I was like, I won't take it personal. I don't have a book, because everybody seems to be absolutely round the clock. But I mean, the thing that I really like about the books that you've put out and the books in our community is they're not fluff. They're not just like, hey, we're just writing a book so we can write a book. I mean, it really does have a lot of really good information. You also tell us a little bit about your role at Shepherd Pratt. I know you guys sponsored the conference this year, and then that's going to kind of transition into my first question. At Shepherd Pratt, I know that you see pretty severe cases. One thing that I'm always curious about to hear from clinicians is, what do you see, whether that's a mindset or an action plan or something people are embracing in the clients that seem to do well in treatment? Not saying that it's a comparison, of course, but there's a lot of people watching these streams and they're like, hey, I hear and see that people are getting better. What is it? What is it that they do that maybe I'm having a little bit of resistance to that really seems to help people, especially, in your case, seeing a lot more severe cases?
So I'll answer your question maybe, and I'll jump around a little bit. So I want to initially respond to just that last part of your question of, what really makes the difference in treatment overall. And I don't think it's exclusive to OCD, because people with trauma, with undiagnosed challenges that come with neurodivergence or mood disorders, any number of substance use disorders, like this, it's not like those things are easier to deal with than OCD. So everybody kind of arrives at the level of suffering where they determine this is more suffering than I should be expected to just endure. I need to change something. And so why do some people kind of land in treatment and hit the ground running and start to improve, and others take a very long time? I think there's probably no easy simple answer to that. A lot of it has to do with trust, and that's a two-way street. So do you have the ability to trust a treatment provider when they tell you this is OCD and here's how we're going to treat it and here's why ERP works? Because you don't know them, right? And so you might have a long history of having your trust violated, and that might make it more difficult for you to even take in what this person's offering. And then also on the other side of that, is the clinician good at conveying that trust and at actually showing you that they care about you as a human being and not just as like, okay, next patient, right? So that's a much different kind of relationship. The thing I come back to the most often, and I think it makes sense because we have entire treatment protocols that are about this, is the issue of psychological rigidity or psychological flexibility. So it's people who are willing to consider that even though their instincts might have been conditioned to approach something in one way, there might be another way to approach it. So it's that combination of, can I trust that my provider's giving me useful information? And can I also have the flexibility to shift over to that information and try it out? Because if you get stuck at either of those points, that just makes it very difficult to connect with the treatment. Hi, Liz.
Hi, guys. Sorry. Good to see you all.
So I was just, yeah, so that's the sort of short answer to your question is what's the secret sauce? It's a combination of trust and psychological flexibility. And of course, part of the treatment is increasing trust and psychological flexibility. To your other question, who am I? So I direct the Center for OCD and Anxiety at Shepherd Pratt, which is a large private nonprofit mental health hospital in Maryland, in Towson, Maryland. And we have the areas where I'm most active are two areas. One is the actual Center for OCD, which is an outpatient center that runs similarly to your standard, kind of OCD private practice. So people come in, once a week or a few times a week, or we have groups, things like that. All specializing in OCD and related disorders. And I have this wonderful team of 8 clinicians who have their own, special interests and skills, whether it's ACT, or radically open DBT, and cognitive processing therapy for trauma. But of course, we all do mindfulness and ERP. And then we have the retreat, which is our adult psychiatric residential program. And so this is a general psychiatric program. So people come to us for, all types of issues. But when they come here for OCD, and 9 times out of 10, it's OCD plus, because by the time you need residential treatment, you've probably scooped up some other challenges. It's obviously gotten in your way. And that, the way in which OCD can impair someone can create other problems, right? You might be having problems at work, or problem in your relationships, or you might be struggling with co-occurring trauma or mood disorders or substance use disorders. So that's really our specialty, is OCD plus. So when somebody comes to the retreat and I know they have OCD, like I read the pre-screen information. When they get here, we do an evaluation. How much of this is OCD? How much of the pie is made up of OCD? And then we kind of tailor the program around that. So maybe you're going to see someone from my team a few times a week, or maybe you're going to see multiple members of my team a few times a day, just based on what we think your needs are. And then trying to balance that out with all the other needs you might have, and of course, our general programming. And what's amazing about it is we see people just so stuck and really in sometimes like the darkest place that they've ever imagined, and they're really impressed by, I thought this was rock bottom. No, actually this is rock bottom. Wait, no, there's another rock bottom. So we catch them in those very dark places and get to see them turn around and build their lives back together. And that's what could be more rewarding than that as a clinician.
Can I ask both of you, one of the things that's just sparked, I run support groups, and sometimes the questions that come in Tuesday always like roll into this. And if you're watching, we're going to get to questions soon. But we had a new member yesterday, and he's just feeling really hopeless. And I think for some reason, there's still kind of the buzz out there, is I think on Reddit and other platforms, is that people don't get better. I know both of you see people get better all the time. You have lived experience about getting better. Why should people be hopeful? What are some of the things that you've seen people, maybe give like some specific examples of like, when people come to you guys, what do you see are some of the typical things before, like maybe not working or not leaving the house? And what are some of the things that you see people being able to do before they leave? Because I think we know that there's hope and we know that people get better, but for some reason, I'm consistently flooded by comments of like, I'm never going to get better. I saw a Facebook post the other day. It was something I think Edna Foe or someone posted, and all the comments were like, there is no hope for this disorder. I've had it forever. Nobody gets better. So what are some of those success things that you both see with people getting help?
Let me just start by saying, maybe you guys have noticed this. I don't know Edna Foe personally, but she is putting out some banger material online about ERP and how it really works, and really clarifying some misconceptions about it. That it's nice to hear from her, having so instrumental in the development of the approach. So, that aside, people, my attitude is there's always another lever to pull. And so wherever you're at, what I think people fail to understand, and it feels cheap when you're in the hole, like hearing it's going to get better doesn't mean a whole lot, because you're in the hole and we're up there outside throwing you the rope and you feel like you can't reach it. But hopelessness is not a baseline state of the human condition, right? We're sort of like, when we come out of the factory, we have certain defaults, most of us. And hope is one of those defaults. Maybe not a lot, but some. So if you're saying you're hopeless, what that means is you're experiencing a symptom caused by depression called hopelessness, right? That's separate from what's happened to you in your life, or what people have let you down, or what things you've tried that didn't work. The experience of hopelessness is in and of itself a symptom that I think should be treated as part of the overarching depression that might be keeping you from being flexible enough to find the next lever. No, this medication didn't work. That's why we're looking for a different medication. Or no, this therapeutic relationship wasn't the right fit. That's why we're looking for another one. Or this wasn't the right treatment setting. That's why we're looking for another one. And people get understandably frustrated, and their inner critic gets very loud, and they start to give up on themselves. And they start to identify with the hopelessness like it's objective reality, like it's wisdom, when actually it's a symptom of a problem that can be treated.
Yeah, and I think that, so many times, we've talked a lot about this on these webinars, Chris, that people think ERP doesn't work for me because to date, maybe it hasn't. And what I...
Oh no, you went silent, Liz. Is she silent for you?
Can y'all hear me now?
Now
you just muted yourself.
Yes.
It's like connecting to audio on my phone and going back and forth. It's so weird. Sorry, guys. But what I was saying is that I think when we hear people say ERP doesn't work for me, one thing we always want to know is like, what did your ERP look like? What did that therapeutic relationship look like? But also, were you in the right level of care? I talk a lot about this, as a lot of us do, is that when your OCD is at a certain level of severity and or you have comorbid conditions, the thought process that once a week, 45-minute sessions with just ERP is going to move the needle just may not be feasible, And so I think it's really important to understand, as Jon said, there are so many levers to pull. And even when I worked with Wayne Goodman on our DBS studies, one of the things, a lot of people who would be looking at DBS, deep brain stimulation, they would feel like this is my last resort. This is my last kind of chance. And Wayne, even as somebody who was like, has been obviously instrumental in DBS and, all of these kind of highest level of cares, he's like, nothing's ever a last resort, right? Like if DBS itself, we don't expect it to be like the only thing, then we augment with different meds and then different interventions and lots of different stuff. And I think that one thing I see over and over in our RES program is that it is very rare that we're seeing people with just OCD, right? Many individuals with OCD have comorbid conditions, whether it's, comorbid trauma diagnosis, personality disorders, depression, substance use disorders, whatever else might be going on. And we need to be treating that comprehensively. And I think that's something that outpatient ERP fails a lot. I see a lot of patients showing up to our program who have been treating certain symptoms with ERP as if they're OCD, and they're actually not. And there's so much value in that individual being educated on the fact that, like, yeah, ERP wasn't working. Yes, it's working for this, but it wasn't working for these interpersonal difficulties because this actually isn't OCD. And I think a lot of times OCD clinicians are anxious to tell people that. They're like, how are they going to respond? What's it going to feel like? But trust me, patients are much more wanting to hear what's actually going on and can become hopeful when they know there's an intervention that'll work for that than us just trying a one-size-fits-all mold for things that we know ERP isn't going to work for, or CBT might not work for, or, vice versa.
All of that. And I would add that what we call ERP kind of can split apart into different categories. So there's this sort of ERP that's like, I took the BTTI, I was trained in ERP, I know how to build a hierarchy and kind of teach people how to overcome a fear ERP, which is essential, and that's the groundwork for someone who's really just dealing with OCD. And you can apply it to a lot of different things. And then there's the more global ERP, which is anytime you are identifying your OCD as not you, you're doing an exposure, right? The golden rule with OCD is that you're supposed to do what it wants because it owns you. And so anytime you're like, yeah, I don't know about this thought, you're already doing exposure therapy because you're taking that risk of turning away from the OCD. And in that context, you can apply ERP to a lot of different things. You wouldn't necessarily say, I'm doing ERP for bipolar disorder, but you might say, hey, it's an exposure to try this new medication for your mood disorder when you've had bad luck with medication in the past. It's an exposure to trust your doctor. It's exposure to ask questions, exposure to say no or yes to something. So we can use that word exposure a lot because I think fundamentally all therapy is some kind of an exposure to something. Otherwise, you just sit there and solve your problems and be done with it. But I think like if I was getting trained now, if this was the beginning of my career and I went somewhere to get trained in ERP, they'd probably kick me out because what I call ERP goes in a lot of different directions. And I think that that's okay. I think you have to, like for anybody who's listening to this who's training and treating OCD, get that foundational training in ERP for OCD, and then try to comprehend how the concepts and the learning that takes place and exposing yourself to something and responding compulsively to it with avoidance and reassurance, actually gets you over a lot of humps in life. And then that's the sort of ERP way of life. And to your point, Liz, like just going in for 45 minutes, and I don't want to say just because that's actually a lot,
Totally.
but going in there 45 minutes and thinking, why didn't ERP work? When actually the ERP works when you start to integrate it into your way of relating to your thoughts.
That's
It doesn't work in the moment that you're learning how to do it.
That's right. And I think y'all hear me talking about, like, my favorite slogan of 2025 is we're fighting for freedom, not functioning. And I think that I can't explain the number of times I talk about this with patients. I did this in my group I run here at our program this Monday. Was many people, as Jon just said, use ERP to function, right? So they use ERP to address this one contaminated cup or that doorknob you can't touch. And that's kind of the basics of ERP, which sure it can be useful, but that fear extinction model is what most of us with OCD talk about when we say ERP is exhausting. That's what most people are talking about. It's like, it's this game of whack-a-mole that I'm having to use it constantly to address a current trigger, to address a current thing that I'm afraid of, versus, am I applying this broadly? Like, am I actually, yes, I'm still going to address the things I'm afraid of, but am I going deeper and doing the core fear work and figuring out why I'm triggered by this and really doing ERP to get me to freedom so that it doesn't keep being this game of whack-a-mole and it isn't jumping all over the place.
Yeah, I think there's a difference between exposing something away and actually standing up for yourself.
Yes.
And a lot of times people are like, I had this trigger, but I exposed it away, and I think that process is basically, it's making discomfort, it's making uncertainty, it's making being triggered the enemy, and it's focusing, very much on getting away from something. Whereas to really internalize ERP is to look at your situation mindfully and say, okay, what are we going to do? What's in my best interest? Can I open up to these feelings and step through this challenge that the OCD is presenting me with?
Just to add, I mean, I think too, one of the things you were talking about, Jon, just somebody that goes to BTTI, those of us that have kind of been in this game for a while and get trained and stuff, start to see like little pockets of treatment areas that people aren't facing. So I know one of the biggest things, I mean, I don't work at the level of care that you guys work at, so I know both of you probably see like this more expansively, but a lot of times when I'm going through what, somebody gets referred to an IOP, what's worked in the past, but I'm always shocked at how many times they've never been discussed mental compulsions. And as we're kind of doing that assessment, they're like, well, I don't get it. Like, I'm not checking the stove anymore. But then they'll report that at work, maybe about 3 to 4 hours throughout the day, they're replaying their morning to see if they, turned off the stove. And I'm like, I would rather you drive home, check the stove for 5 minutes and spend 5 hours all day tuning the world out, being inside, replaying the same thought over and over. And I think that doesn't get addressed. I think additionally, your lifestyle has to change. If you're still doing ERP, let's say once a week, or IOP, whatever level, but you're still like at home, not getting out of the house, not getting a job, not volunteering, not engaging, like your life has to start to change, or else it's like there's so much dead time to just spend thinking about OCD. So I think there's so many additional elements that maybe people haven't really received in treatment that they should be looking at as well. Because I know for me, it was like once I finally found out that, hey, I'm not supposed to just be replaying things, that was a game changer. Because I thought you're just supposed to, I was like, I'm not doing compulsions. I mean, I may be thinking about OCD for 12 hours a day, but at least I'm not washing my hands, but it's like, that's just as bad, right? Like that has to be addressed the same way that physical compulsions are.
Yeah, well, to your point, why'd you wash your hands in the first place? It's because your mental rituals weren't doing enough of the work for you. Because if you could just think your way through, concluding that your hands are certainly clean through, carefully monitoring in your head everything you touch that day, then you wouldn't feel the need to wash your hands. It's because that's ineffective that you then add the physical compulsion. So it's very common that I see people learn to resist their physical compulsions, either because of social pressure or because they're really just doing the best they can to like take in the treatment, and then immediately swap them out with stronger mental compulsions. And it just takes a while to kind of understand that process of, there is a difference between doing or appearing to do less compulsions and being less subservient to your OCD.
Yeah. I want to throw this out to y'all. Croft at 1205 says, hi, is it possible to treat OCD at home? And what are some good ERP teaching resources for parents of young adults?
Yeah. So, I mean, You definitely can do some self-help workbooks and books that can be really great ways to guide ERP and be great resources. But what most of us would say is that it is a lot of research would show actually as well that the most effective results are going to come from in-person ERP with a clinician who specializes in it, at least at the beginning, to kind of get ERP going, to be able to model and practice what it looks like and how it should go while you're in the implementation of ERP phase. So we really want that to be where you start if possible. If not possible, I think there are great self-help books and workbooks out there from lots of individuals we love and trust, and we would definitely want to make sure that you're using those. So it's really important that if you're using self-help resources, that they are rooted in evidence-based intervention. So focus on ERP for OCD. Also, what I will say is that when you're talking about parents of young adults, Chris has an amazing support group. There's a lot of interventions like the space intervention by Ellie Leibovitz that there's also like space for kids, but then there's also space for adults who are struggling still with anxiety and OCD. And those are some interventions that are specific for the parents to learn how to reduce accommodations that then will push patients into treatment.
Yeah, if you're open and interested, I run a large family and loved one support group every second Saturday of the month. If you email info@ocdsocal.org, so that's info@ocdsocal.org, you can join, and it's additional resources for parents. At 12:09, Abdullah asks, how do you treat the always persistent kind of background residual anxiety outside the active obsessions? My mind is always scanning for dangers, uncertainty, and then any minor inconvenience makes me overact.
Well, what I'm hearing there is that first there's a fair amount of mental compulsive behavior going on there, that's sort of like seeking out the dangers instead of being in the present moment. You know, you look out at a room and one is like, oh, there's a room, there's a couch, there's a poster on the wall. Or you look at a room and you go, okay, where are the sharp objects, right? So that separate process might be looked at as compulsive. It might be hard to catch because you might have been doing it for a long time. And so learning to catch it and abandon it with self-compassion might be an additional step necessary. I'm also hearing that there's just as like chronic, anxiety or agitation. So I don't know what the role medication might play in that, or meditation might play with that, or exercise, or other kind of down regulation skills that might actually just help you feel better in your body. One reason why you might be scanning, looking for problems, is that your body is telling your brain something is wrong. And if you don't know what it is, that's very disturbing. So that the tendency would be able to find something. It could be kind of, if you're feeling like something is wrong and then you locate something that you can call wrong, there's something sort of grounding about that, even though it doesn't make you happy. So I think that's something I see with people sometimes. And this sense of like a minor inconvenience making you overreact, that sounds like stress. It sounds like you're sort of like operating at a base level of stress, and the thought process is, I cannot handle any more stress than that, right? I'm gonna snap, I'm gonna lose it. And so you start to tell yourself, I can't cope with things that haven't even happened yet, as opposed to whatever happens next, I'll cope with it somehow. So some of this, I think, has just a lot to do with how you treat yourself in the moment, recognizing, okay, this is how my body's feeling right now. I'm on edge, I'm irritable, I'm tense. What does my body need right now? And that might also cue you into what your mind needs in that moment.
Yeah, no, I remember what a game changer it was. Like, I used to not want to step on things that I found like contaminated or dangerous. And so like if I was parking and walking into a store, I'd scan when I walked. And I just remember how scary it was, but how impactful it was to just look up. My therapist is like, you can't be walking looking down. And it's always funny because giving into OCD is always more dangerous than not, right? Like, I'm like, oh, I don't want to step on something dangerous. Meanwhile, I'm looking down, walking through a busy parking lot. Like, right. Who figured, like, maybe that you shouldn't be doing
right.
that.
I don't want to hit somebody with my car, so I'm going to make sure I look backwards while I drive to make sure I've done that, right?
Exactly. So yeah, I think, we get in such I think of it as like Hunger Games, right? Like everything can kill us. So we're kind of scanning constantly. And it's really important that scanning is looked at as a compulsion. There's a sweet message for you, Jon, at 12:09 from Ashton. They said that one of your books was a game changer in the recovery process. At 12:09, he says, meeting Jon at the conference for my first time felt full circle in my recovery. Oh,
that's wonderful. Nice to hear from you, Ashton.
Terracotta says at 12:09, I've been working on my OCD and my therapist, but I'm not sure if mindfulness can get muddled with mental noting and compulsively noting every moment or thought that comes up. So sometimes people will learn about the treatment and learn about, okay, let's start kind of identifying thoughts, intrusive thoughts, etc. And then people can become compulsive with the treatment. So in Terracotta's question, maybe expansive for you too, how do people prevent from actually making the treatment start to become, or mindfulness become compulsive?
Yeah, I can hop in here. I think this is a good question. It's one I get a lot, and it's one I see a lot, where I see individuals saying things like, Liz, I'm doing attention switching, or I'm trying to do some mindfulness to think about something else, but my thoughts are still showing up. My intrusive thoughts are still there. Like, treatment's not working. And my point is that while those things can be really useful tools in different ways, they're still not OCD treatment, right? We still have to do ERP. So if we are trying to kind of track things or write them down or switch our attention instead of facing our fear, it becomes kind of another way to suppress our intrusive thoughts, in which they end up continuing to show up and be present and not be there. And so we still have to do ERP. We still have to face, address, walk towards our fear so that it doesn't control us. And I think that the same goes for kind of this, I guess I would want to know, what is the function of mental noting and compulsively noting every moment or thought? Why would that be helpful? Why does your clinician want you to do that? Because it does feel like that for people with OCD would probably not be super helpful. Unless it's just that, oh, it's the first week, I would like you to make note of the different triggers you're having and the different rituals you're having, so that then y'all can start to do some ERP together around it. And she's just trying to get you to bring some awareness to all the different ways OCD shows up in your life. But long-term, noting and keeping count of and keeping track of all of our compulsions is not typically going to be a helpful, treatment behavior.
I would just, on the mindfulness front, what is mindfulness? It's paying attention to the present moment without judgment. Well, most of us are pretty good at paying attention to the present moment and then saying, I don't like it. And so we leave off that part about the non-judgment, which is the most important part of it. So, to this particular commenter, the mental noting, and I mean, maybe it's compulsive, maybe it isn't, but noting every moment or thought that comes up is not a problem. Judging that experience is very likely to be the problem. So you're aware of your thoughts as they arise, and you're saying, I like these thoughts, I don't like these thoughts, and I shouldn't be having these thoughts, and why am I having these thoughts? And now I'm noting too much, and I'm not noting the right amount. All of that's judgment, instead of just showing up to the experience as you're having it. So if your mind content involves, whatever thoughts, it gets back to what Liz was talking about before about, somebody talking about, I'm doing all these activities, but I'm still having intrusive thoughts. The perspective of them as intruders is a bigger problem than their existence. And so I would encourage everybody to really pay attention to the tone. You can mentally note all day. Everybody mentally notes all day. Oh, this is good coffee. Oh, I like this breeze, right? That's what it is to have a consciousness. But then there's the secondary process of, why am I thinking this? I shouldn't have this thought. I'm a bad person, all that stuff. So I would work on just, okay, so you're noting a lot. Okay, you're noting the amount that you're noting. What would it be like if you didn't? Why are you monitoring that so heavily, right? Because you're trying to do it right. What if you let go of this whole idea of doing it right or doing it wrong, and you just let it arise and, treat yourself like you're not constantly trying to pass some sort of test. And that stuff might be very deeply ingrained, might come from a very old place. It also might come from a place that isn't OCD. Anthony Pinto and his colleague, Dr. Wheaton, recently wrote an OCPD workbook. It hasn't come out yet, but when you're in the circle, you get to see these things early on. And I wrote the foreword for it. I was very happy to do it. And I learned a lot, including that it's much more common than OCD, and that hadn't even crossed my mind. And I think there are a lot of people out there. And the reason why I'm bringing this up is because OCPD often is I'm not suggesting this person hasn't necessarily, but it is characterized by a lot of self-judgment, a lot of this should be this way and that should be that way, and this is how it's supposed to be done. And if I'm not doing it right, then it means then something is wrong and I need to fix it. And so it's that rigidity that sometimes makes it difficult for people to find that flexibility that they need to incorporate mindfulness in ERP.
I think additionally, what I always remind people when they're doing the treatment compulsively is like, and they want to do it right, it's like that comes from a good place. You want to get better. The problem is the way you're going about it, right? Like you're not kind of grasping the overall concept of ERP, which you were saying earlier, John, is deciding like, I am no longer going to listen to everything you say, give in to everything you do, and really kind of start to take my own direction despite the alarm bells going off. But I'll have clients that are like, okay, you said to do, this 6 times, but I could only do it 5 times. I failed. And I'm like, okay, now we're just getting too compulsive. I was like, what did you learn? What did you gain from it? Right. There was a pre-submitted question, but I'm going to also have you throw up the question or the comment at 1221 Emilio from Stevens S. He says CPTSD and OCD can intertwine. The pre-submitted question was asking, like, when you do have co-occurring disorders, and I know both of you talked about it, whether it's trauma, depression, the question was, are all those treated the same? Do you treat them at the same time? So I think a lot of people ask, like, do you see the same provider? Do you treat them at the same time? Which one goes first? Do they have different treatments? So can you both just talk a little bit when people have co-occurring disorders? How do you sort of assess and address that?
I could like write a novel on this right now, just because this is my current soapbox. It's also Dr. Poskar's and some others, but I think that I just want to remind clinicians that it is so, so critical when someone comes to you for OCD or anxiety that you are doing a full intake, right? And when we do a full intake, it is our job as clinicians. And this is why, you guys, I don't recommend life coaches. I don't recommend non-licensed clinicians who haven't had experience, background, education, and training to be able to truly understand the full psychological picture that you're presenting with. But it is our job to assess for everything when someone shows up in our office, right? Just because, I'm making this up, but Chris, if you show up in my office and you're exhibiting symptoms of OCD, it doesn't mean you only have OCD, even if you have OCD, right? And so yes, it might be my job to say, oh, there's OCD going on, and this is what's the evidence-based treatment for OCD, and this is what it can look like if we do that together. But it's also my job to make sure there's not other things going on, right? And do you have trauma history, eating disorder history, current or active other diagnoses or symptoms? And I need to ask the right questions. I need to understand that. But I also need to, as I'm working with you, be able to pivot and understand if differential diagnoses are starting to show up. So, John, I'm sure you see this too, but I cannot describe the number of individuals that come to our program with certain diagnosis, maybe oftentimes just anxiety or OCD. And really, there's actually a lot of other stuff going on. And many times, actually, there's not OCD at all, right? That's not always the case, but that happens. And that makes sense why ERP hasn't worked and this person hasn't gotten better, because that actually wouldn't have been the evidence-based intervention for what's going on. I think that I see most frequently personality disorders and personality disorder symptoms comorbid with anxiety and OCD, but like comorbid for sure with severe OCD not being appropriately identified, and the individual thinking this is all OCD, but then they're getting stuck as they're trying to apply ERP to some interpersonal difficulties that are going on, or emotion regulation, dysregulation that needs to be addressed, and it's not working the same way. So, I think to answer the question, it really just depends. I think most outpatient clinicians who are treating just OCD may not be able to treat as much of comorbidities going on. I hope if you are in a higher level of care, like programs John or I run that are at the residential and higher level of cares for anxiety and OCD, we have to be able to treat differentials. We have to be trained in them because we rarely are seeing just one diagnosis. But as far as separately or together, that depends on the expertise of the clinician you're working with. Right. If the clinician, for example, like substance use is not my specialty. It's not my area of expertise. Neither is psychosis. That doesn't mean we don't take patients who have comorbid substance use disorders or comorbid psychotic illnesses, but those need to be stabilized for them to be a fit for our program. Because if those are active, they're not going to be able to engage in ERP, and that's not our area of expertise. It's also not what all of our groups, treatment and programming, are focused on. And so they're not going to get the same benefit from the program as somebody who now has primary OCD. So many times disorders can be treated in tandem. I think in particular, if we're talking about like comorbid anxiety disorders or OC related disorders like BDD and hoarding disorder, oftentimes that same provider can treat those, but there's many times you may need a team, and that comprehensive team should still be working together. But John, I know your expertise and bread and butter over at Shepherd Pratt is often these pretty significant comorbidities. So would love to hear your thoughts.
Well, I'm spoiled because I get to work with other clinicians at the same time. So we look at these conditions. A lot of people think like, oh, I've got 4 diagnoses. I'm like 4 times a burden to society as other people. They get really down on themselves. But we look at these conditions like stars in the constellation. And, what that means is, here's your OCD and here's your trauma and here's your substance use issue and here's your personality disorder. And it makes a shape if you look at it in the right way. We're treating your mental health. We're treating that shape. I might focus more on this star and this other clinician is going to focus more on this star, but we're all kind of working together at the same time. In outpatient settings, it's very difficult to do. It was one of the reasons why I decided to take the opportunity to come to Shepherd Pratt, because I found myself working with people and I could tell, I was like, something other than OCD going on here. I don't know how to treat it, but there's a good working relationship, and so I'm going to just wing it. And that never felt good. It never felt right. I mean, I'm not saying that it never worked, but there were times where it was like, I know this person's needs more, and if I tell them to go over there and fix it, it's gonna feel like abandonment. And so I'm very fortunate to work in this residential environment where I don't have to tell them to go somewhere. I have to tell them to just stay here, so we can all work on it together. These conditions are interactive. So to the question of like, do they get treated separately or together? I don't think you can really truly effectively treat anything totally separate from the OCD, because the OCD is very opportunistic and has an opinion about everything. So when you're maybe think that you're treating your trauma and your OCD is like, well, what do you think about this? And it'll come up with stuff to get in the way of your trauma treatment. I see it all the time. Or it might be judging you for talking about the things that happened to you, or it might be telling you, it might be colluding with the trauma. A lot of times I see people with trauma and OCD where the trauma is sort of using the OCD as an additional layer of cover to keep from being re-traumatized. And then I come along and peel away that layer of cover, and now they have to deal directly with the trauma, but they don't have any skills because they never had any trauma treatment. Or someone's working on, you name it, their mood disorder or substance use disorder. Again, if we're going to accept the claim that OCD targets the things that matter to you most, then when you take the risk of trying to get well, that's going to matter to you the most. Your OCD is going to have an opinion about it. You're going to have obsessions and compulsions related to your treatment. So if OCD is a major player in the constellation, I don't think you can put it on hold, treat the other stuff, and then come back to it. I think you have to be mindful of it the whole time. And that's why the other clinicians who might be treating these other disorders need to also be educated on OCD. They don't have to necessarily be doing the ERP, but you certainly don't want them undoing it. And that's a big risk that you take in the outpatient world.
That's right. 100%.
Glad you brought that point, because that's so true. I think we definitely want to address this question. So this is from Amy on Facebook. She says at 12:24, my daughter said a therapist she consulted with does DBT, which is dialectical behavioral therapy for OCD. The therapist said it's a newer therapy for OCD. Does that make sense to you? I've never heard that.
No, it doesn't. So DBT is not an evidence-based first-line intervention for OCD. As a reminder, you can go to iocdf.org and look up our treatment guidelines, where we've worked really hard to work with leading experts in OCD and leading researchers to make sure those are up to date and active. ERP remains the frontline behavioral therapy intervention for OCD. That does not mean majority of at least our patients in the residential level of care don't also benefit from some DBT skills, right? A lot of our patients have, again, comorbidities that DBT would be an evidence-based intervention for. So personality disorders, individuals really struggling with emotion regulation, right? There's times where suicidality, there's times where DBT is a very effective intervention, but DBT by itself has not been proven to be effective for OCD. It's kind of, I've heard EMDR like resurface a lot for OCD, of people talking about doing EMDR for OCD. Again, EMDR is a newer line evidence-based intervention for trauma, for PTSD. And so, of course, if you have a comorbid PTSD condition, EMDR might be useful for the PTSD, but EMDR is not a frontline intervention for OCD.
Yeah, I'll add some additional thoughts on that. I agree with everything that Liz just said. I think that first of all, I don't understand the claim that it's a newer therapy for OCD, because it's not a newer therapy in general, DBT. What I will say is that the way ERP works is you get in front of the thing that is triggering you, and you work through the distress that it causes you in a different way than doing your compulsions. And you come out on the other side of that and you've learned something. I can tolerate the uncertainty. This thing's not as scary as I thought. I'm not my thoughts. Whatever it is that you learn something, and you take that into your next battle with the OCD. And in order to do that, you need to be present throughout the whole experience. So if you are doing exposure therapy and you get so dysregulated that you brown out, that you panic, that you become dissociated, that you become immersed in suicidal thinking and self-harm urges and things like that, then you're not going to learn anything from that experience other than that it was too hard, which is what you thought going into it. So it kind of goes back to what we were talking about before about what are we calling ERP, because DBT also has sort of two worlds. There's the sort of DBT protocol, but then there's also just good emotion regulation skills and learning how to take care of your mind and your body and your spirit when you need tools for that. And so for that second one, I still call that DBT. So I use a lot of DBT in my ERP work. Am I using DBT to treat OCD? No, I'm using ERP to treat OCD. But for many individuals without that emotion regulation, distress tolerance, interpersonal communication, mindfulness, without those elements, the ERP is not going to stick. So but again, back to what Liz was saying, if you're just saying like I use DBT for OCD, I don't think that that's an accurate or evidence-based statement.
Yeah, and this is similar, by the way, for ACT, right? We hear a lot of people talking about ACT for OCD. Like ACT with ERP can be a very useful intervention, but ACT alone doesn't replace ERP. You still have to be doing exposures with response prevention. And trust me, mostly all of us with OCD would love to be able to avoid the exposure part and the response prevention, but it's the integral part of treatment. It's like Jon said, like the whole goal of treatment is to face our fears, not run from them, right? And so the only way to get rid of a fear is to face it head on. It's not to try to suppress it. It's not to try to ignore it. It's not to try to distract ourselves.
And this might be annoying to some people, but I'm gonna take a risk here. The reason why people say they want to avoid the exposure part is because they have associations with exposure that are missing the point. Life is exposure. Exposure can be joyous, can be exciting. Anything that's new, you are being exposed to. And the reason why we think about exposure in OCD as being painful and difficult is because you've already pre-established judgment about these thoughts and feelings and the fact that you're having them. And so when you look at that, it feels bad. A good, healthy brain does not automatically and very quickly go from danger learning, fear learning to safety learning. You would not want a brain that does that. You definitely want a brain that once you teach something is dangerous is very slow to learn that it's safe. But we find ourselves in these situations where we've inadvertently taught ourselves that touching this is dangerous, thinking this is dangerous, whatever it is. And then we go, oh, wait a minute, now I understand this is my OCD, so I'm going to turn that around. And your brain is going to say, don't do that. That's a terrible idea. And that's the discomfort part of doing exposure therapy. But exposure in and of it, and of course we want to avoid discomfort, that makes sense. But if you understand where that discomfort is coming from, then exposure can and I think should be passionate, should be exciting. And I think a lot of this negative things that we hear about ERP, it just has to do with people associating it like with only the distress part and missing the bigger picture.
Yeah, that's why I agree with you. Edna Foa's stuff has been fire because she's done really well to explain it. The only thing I wanted to add to this is like, I think because I come from a media and PR background, it really, really bothers me the way that some therapists are pitching things, right? Because I think words matter. All of us with OCD are in such vulnerable places. And so when people are marketing therapies like, oh, ERP is really hard, don't mind that, you don't have to do exposures. DBT is a new therapy, try that. I mean, this isn't a new sponge, right? This isn't a new product. We're not marketing a new soda. We know that ERP is extremely effective. I remember even my professor in when we were talking about the DSM and treatments, who had no connection with OCD whatsoever. When we got to the section on OCD, she said the one like silver lining with OCD is, this professor just happened to treat substance use. And she was talking about how it takes on average 9 different rehab experiences for people to be to kind of start their sobriety journey or whatever that journey looks like. And she, who doesn't even in our field, had said, exposure with response prevention is really effective and people with OCD get better. And that's kind of like the hope with this disorder, despite it being absolutely terrorizing to have your mind attack you, at least there's great treatment. So how I would like clinicians to present other modalities is like, hey, we have a really effective frontline, but there's these great adjunctives like DBT or ACT and stuff, mindfulness, that can be paired and infused. There's also second line, there's also medications, right? But when people are like, oh, don't worry, there's a new thing. If I was that desperate and I was going in, I'm trusting that clinician to provide me with the best service. I have obstructive sleep apnea. If the person I worked with was like, hey, there's a surgery you can get. Well, I'm glad I use a CPAP instead of getting a surgery, right? Like, and getting something put in my chest. Like, there's a reason there's frontline. It's not because there's a group of people behind the scenes trying to make it frontline. It's because we know it's effective. And so I just caution, if anybody watching, if there's somebody that's saying there's a new therapy, it's way better, it's better than that old ERP stuff, please be cautious. This is your mental health. This is not a product we're buying. It really bothers me.
I like that idea that I work for big ERP.
Right? I'm like, where is it? It's not in my bank account.
I know, Chris and I always talk about that. We're like, people think we get like a kickback every time we say ERP. And we're like, yeah, there's not big ERP. We're not big pharma here, but but we're personal individuals with lived experience who know what it's like to get the wrong treatment and know the life-changing impact of the right treatment. And it's not just about us. It's about what we witness every day, but what research tells us, right? We don't use our own personal experience to guide the clinical feedback we're giving, right? That is based on research. It's based on evidence. It's based on decades of controlled clinical trials. And IOCDF is doing a great job of really making sure that the work and treatment recommendations that are published are based specifically on that. And so I think the biggest thing is think about what is a trusted resource that I can feel really good about getting my guidance from.
Yeah. I think we have time for this last question. Max asked.
Sorry to interrupt y'all. Where do I find Edna's stuff? Because
it shows up in my news feed. Probably because they say the word ERP a lot and they're all listening.
I started seeing it. So I only go to Facebook because of Michelle Massey and Allison's group on Facebook, because there's so many good people on there. A lot of times I learn from people on there. But her stuff has just been popping up on Facebook. And I think what's so great, right, is like, because some people unfortunately are villainizing ERP, when people talk about ERP in a negative manner, I love that the person that had such an influential part in designing it isn't even saying the same thing as the person that's saying bad things about ERP. I mean, a lot of the stuff that we've been saying, she says, right? And she has been explaining it. I think you're great at it, Jon. I think you're great at it, Liz. Is like, there was an account, I still have this saved to this day, but there was an account of somebody that's overcome OCD using ERP. And he said, I love ERP because all of the exposures I did, those things I did exposures on, are now valued things in my life. And so, like, I had a client with POCD who is now able to hold her child. She wasn't able to hold her child for the first 6 months. And it's like, sure, it wasn't pleasant because of how her mind attacked her, but now she's like grateful, right? Like, so she's just really good. We'll have to send it to you, Liz, because it's on Facebook. It's just really good. She's really explaining ERP and the beauty of it. I think it can sometimes look like it's torture chamber, and it's just not. Max asked at 12:34, last question. How does treatment differ for sensorimotor hyperawareness OCD compared to the more standard themes? As with hyperawareness, you're already exposed to sensations like blinking or thinking.
So there's a lot of different ways that this shows up. And I don't think we have a very good understanding of how sensorimotor OCD works. I think there's some reason, I think, to believe that for some individuals, it is a little bit different from standard, like contamination OCD or checking OCD. And for some, it isn't any different. I see sometimes it's co-occurring with depression, right? When the depression is lifted, then there are less somatic complaints and there's less attention being drawn to what feels wrong in the body, right? And so is that OCD, or is that OCD being an opportunistic disorder, seeing that you're depressed? I don't know. But to the question about, like, how do you deal with it from an ERP perspective, you are already being exposed to this conscious awareness of your semi-voluntary process, but you are experiencing it from the defensive position. So it's happening to you and you're going, I don't like it, I want it to stop. And then you have your various strategies for trying to get it to stop. ERP would say, let's flip the tables here and do it from an offensive position. Let's choose to think about our blinking. Let's choose to bring our awareness to our blinking. Let's say I'm doing this on purpose. And then you're like, but I don't want to do it. Okay, but that's not response prevention. That's the judgment. Let's want to do it. I make everybody watch Reed Wilson's acceptance speech from the 2019 IOCDF conference.
I love that.
Where he breaks it down, and it's this. He keeps coming back to, you have to want what you don't want, and that this would be a good example of that. What the OCD is capitalizing on is your assumption that you cannot handle having these thoughts, and that the only thing you can do is try really hard to get away from them. And so you can turn that upside down and choose to have the thoughts and be with thoughts and notice thoughts. It doesn't mean you have to believe the thoughts. Maybe a thought like, I'm going to think about my blinking for the rest of my life. Okay, right? What the OCD really does that drives people, it makes them really frustrated, is it takes things that are not threatening and puts them out of context. And out of context, they appear threatening. If you were writing a screenplay about a character who kills people, and you said, and then they stab people and they laugh about it, you would not find that threatening. But if you're just having a polite conversation with your friend and you have a thought about stabbing someone, you're going to be very upset. So the thought about stabbing people is not the issue. It's the way you're relating to how it presents in the context. And the OCD is purposely putting it in a different context to throw you, because it has one job, and it's to throw you, and you have many things to do. And that's why it's sometimes hard to deal with. But to answer this question, I would say shift from defensive to offensive, and that's what turns it into exposure therapy.
My favorite, also second favorite slogan for 2025 is, I know I already gave you all one, so you're like, you already said that, is just bring it on. And I always talk about that. Like, do we have this bring it on attitude that we're like not passive, but we're active and we're like not afraid and we're approaching it, versus, oh, I hope this doesn't happen. I hope I don't have to deal with it. I was talking to someone the other day about panic disorder treatment, and they called me to ask, what should we look for in a clinician for our daughter? And I said, well, the biggest thing I would look for is the treatment they're talking about active treatment or passive? So are they trying to give you things to not have to feel panic, to hope that you can avoid it, to hope that you can not be anxious? Or is it an active treatment approach where you're approaching panic, you're approaching anxiety, you're sending the message you're not afraid of it? And ERP is the same.
Awesome. All right, let's do final thoughts. I'll go first, and then Liz, and then we'll give you the floor, John. There's a couple questions, real quick, a couple things. There's a couple questions about DBT, ACT, and ICBT. What I'd really recommend is go to the IOCDF's post on evidence-based treatments, because one cool thing is if you click on each treatment, it gives you information. Gail made a comment that she said that she's been finally doing facing her ERP, and she said, is it normal to feel both anxious and freer? Absolutely. ERP equals freedom. Somebody asked, how do you spell Michelle Massey? Because I think their clinician wants to join her Facebook group. You spelled it right. So the way you spelled it is right. And then lastly, somebody asked,
OCD and BFRBs.
Yeah, it's OCD, anxiety, BFRBs. And then somebody asked about the time of the group. It's every second Saturday of the month, 11 to 1 p.m. Just email info@ocdsocal.org. And that way you can join us. The only other announcements is the IOCDF is hosting an all Spanish conference this month in September. So please head over to iocdf.org/conferences. And then if you're a clinician who wants to get advanced training in pediatrics BTTI, that will be in the third week of October in Long Beach. So check out all that the IOCDF has to offer. How about for you, Liz?
I don't have much to add. I love this organization. I'm grateful to be a part of it. And I think that it's so amazing to have a sound kind of governing body that that the product, so like the information, the education that you're getting is sound and backed by research and evidence. And just remember that treatment can get you to a place of freedom. Treatment doesn't have to be that we have to use ERP our entire life to just try to be able to function. And I think that's a big shift I want us to push towards, is that old school, when I was first diagnosed, it was this OCD is a chronic condition. You'll have it your whole life. You're always going to struggle. You just want to learn to be functional and manage symptoms. And I think that set us back a little bit. And we know that doesn't have to be the case.
Yeah, I don't like being told what to think, even by my own mind. So that's my quote for the year. I want to use this 10 seconds we have to actually plug the first annual OCD Mid-Atlantic conference that we're doing here in Maryland, here at Shepherd Pratt. So the OCD Mid-Atlantic is an affiliate of the IOCDF. It covers Maryland, DC, and Virginia. And Shepherd Pratt are collaborating on a half-day-long conference where we're going to have 4 amazing speakers do advanced level trainings, and then end with a lived experience panel. And you can attend it live here at the conference center at Shepherd Pratt, but you can also watch it live online. And also the CE portions of those talks will be available later on demand. And it's all free. And so we're very excited to do that on October 17th, the Friday, right in the middle of OCD Awareness Week. So, go to cme.shepherdpratt.org, and you get more information on how to sign up and register for all of that. And we hope you enjoy it and learn.
Yes, and both of you are going to be speaking at OCD SoCal's conference in November. So I'm excited to see both of y'all. Thank you so much, Jon. It's always great having you on. You're always welcome back. Thank you so much. And Liz, thank you for coming on and making Jon and I look that less attractive. So thanks a lot. Everyone have a great.
It's good to see you
guys.
Yes, everyone remember, OCD absolutely is something that you can overcome. We're all living proof. We enjoy that you spent some time with us on a Wednesday. Take care and have a great rest of your day. Thanks.
Bye, guys.
Bye.